Good evening, everyone. I welcome you all to the second session of Autism SIG. We had a wonderful session last week. Today also we'll be having two webinars by international experts. I request our President Dr. Shafala Gulati ma'am to introduce the speakers for today, the moderator for today's session, and the experts for today's session. Over to you, ma'am.
Thank you. Thank you. Asmita, can you start sharing the screen? Good morning, good afternoon, good evening. Welcome you all to this session. We are going to be talking, last week we had spoken about autism mimics, and today we are going to have learn autism from the leading experts on autism, leading global experts. The first talk is going to be Autism from 2 to 32 by Professor Catherine Lord, and the second talk would be an early intervention model for children with autism aimed at social communication and language outcomes by Professor Connie Karsari. Both of them are global icons in autism spectrum disorder. Professor Catherine Lord is a George Sturgeon Distinguished Professor of Psychiatry in the David Geffen School of Medicine, UCLA, California, with the PhD in psychology with over 300 referred publications, is a recipient of Lifetime Achievement Award from the International Society for Autism Research and member of National Academy of Medicine, fellow of the American Association of Arts and Sciences, and professor former chair of a National Academy of Science Committee on the Effectiveness on Early Intervention in ASD. And she's co-chair of the New York Board of Health Committee on Autism Spectrum Disorder and member of the DSM-5 American Psychiatry Association's Neurodevelopmental Disorders Committee. We are really grateful to have you, Professor Catherine. Followed this talk by Professor Catherine would be Professor Connie Kansari. She is a distinguished professor and of psychiatry in David Geffen School of Medicine in UCLA, California, and with the PhD and International Review of Research in Mental Retardation. She is an associate editor and consulting editor of Autism Research and Treatment, Down Syndrome Quarterly, and Infants and Young Children. She was the president of International Society for Autism Research from 2021 to 2023, and she's the INSAR Fellow, and she's got Harold A. Lewis Hayton Research Award and 2017 Autism Speaks Acceleration Award, and also a WHO consultant and a Distinguished Professional Award, Help Group Los Angeles, and did a postdoctoral fellow in UCLA School of Medicine. Thank you so much, and it's early morning for both of you. We're really grateful to you that you have joined. We will be having the tradition of having diverse resource or diverse kind of professionals who will be there for discussion. Would be Miss Mary Barua, who's founder director Action for Autism, National Center for Autism, and a dear friend. She serves on various committees of the Rehab Council of India and for Department of Empowerment of Persons with Disability and National Council for Education, Research and Training and WHO. She got the Javed Abidi Public Policy Award 2022, Advocate Award for the International Society for Autism Research, and Limca People of the Year Award 2013, IBN 7 Super Idol Award, and many, many more awards. And she has basically been a pioneer for increasing the awareness and advocacy of autism in India and beyond. Then we have Brigadier Shubhendu Roy, who is professor and head of pediatrics in Armed Forces Medical College, and he's done MD in pediatrics and fellowship in pediatric neurology, and areas of interest are epilepsy, and has had 40 publications. And Dr. M.K.C. Nair, who's Professor Emeritus in Developmental Behavior and Adolescent Pediatrics in Child Development Center, Thiruvananthapuram, and was former Vice Chancellor of the Kerala University of Health Sciences. He's a doctorate of science with an interest in developmental pediatrics, adolescent premarital newlywed counseling. He's a founder director of Child Development Center. And he was the national president of the National Neonatology Forum and national president of Indian Academy of Pediatrics. Sir may be joining a bit late because of some medical emergency in his family. And then we have Professor Paul Russell, who is currently the Senior Professor, Child and Adolescent Psychiatry Unit he's in CMC Vellore currently and was heading the Department of Psychiatry there. He's author of 167 international and national index papers and has edited 2 editions of the Illingworth's Book of Child Development and is on many editorial board. He has also been bestowed Doctors of Science. And the whole proceedings would be moderated by Dr. Prajita. She is a colonel. She has been I have the privilege to be her teacher, and she has studied pediatric neurology under us, with us, and she's currently associate professor, pediatric neurologist in Advanced Care Center for Pediatrics, Army Hospital in New Delhi, and she has done her DM dissertation with me on autism and early diagnosis. And over to you, Prajita.
Good evening, everyone. Without wasting much time, I would like to invite Dr. Catherine Lord for her first talk on autism 2 to 32. Dr. Catherine Lord, please.
Hello, everybody. It's very nice to be here. What I'm going to do is talk to you about a single study where we followed children who were referred for autism or possible autism at age 2, who are now actually 32 years old. And what I hope to do is give you a positive but realistic description of what has happened to them. And it's very nice to be talking to you. Oops, oh dear. Let's see, what do I have to do to get the slide to move? There we go. I do need to say at the start that I get royalties from the diagnostic instruments. I am not trying to sell you anything today, but you should be aware of that. And I have grants from a variety of different sources, and we are coding data for several pharmaceutical companies. So I think we want to start with something that everybody knows, which is that autism is a neurobiological condition that's probably present before a child is born that affects learning and processing. And I think what's important about that is that having autism changes basic aspects of behavior, how quickly a child looks at you, how much a child vocalizes, what they're paying attention to, and perhaps to some degree, what is motivating them. These different perspectives in an autistic child can affect learning because, for example, if a child doesn't look at their mother right away when they hear her talking, they're going to take in less information about what she says. They also affect opportunities for learning in that if a child doesn't seem interested or is harder to engage, they may have fewer opportunities. I think the good news about this is, though, these are things we can change. And I put this picture here because this little boy is doing something that's classically autistic, which is that he's brought his mother a toy. It needs to be pushed to operate it. And rather than looking at her and vocalizing and assuming she'll know what to do, he is taking her hand and pushing the toy with it. So he's communicating with her, but not in a very efficient way. We know that there are a variety of causes for autism. Certainly genetics plays a major component, but we haven't figured out the genetics for all autistic kids by any means. And we also know that there's huge variability in how autism is manifested in different children and adults. And so I think we keep hoping that in the middle there will be final common pathways in terms of brain mechanisms leading to autism. And we have some ideas, but no answers. I think making this even more complicated, we have a child who's diagnosed with autism is diagnosed because of social and communication deficits, because of restricted interests and sensory behaviors, but very likely has other issues too. And very few kids have all of these things, but many kids with autism also have ADHD. Some will be aggressive. Many will have social anxiety. Some will have intellectual disabilities or motor problems or language problems. So we need to keep in mind all of these things. So a long time ago, in the late 80s, we received a grant to use multiple measures, including both parent reports and direct observations, to look at kids who were referred for autism under age 3. And we were able to see 192 consecutive referrals for autism in North Carolina at the TEACH program and then in Chicago. We also added 21 children who weren't referred for autism, but were referred for neurodevelopmental disorders. And then we've later added 54 more kids from Michigan who are the same age, had earlier referrals, but we didn't meet them till they were about 9. This sample is unusual because it was started so long ago. About 75% of the children in the study are white. The rest are African American. We have very few other minorities because of where the data were collected. But many of these children are rural in North Carolina and even outside in Michigan, as well as being urban and suburban. And this is an example of one of the little guys we first met. I think we were really surprised when we first met them, how amazingly cute the kids were, how happy many of them were, but also sometimes how hard it was to get them to do things. And this is another little girl who is 2. And you'll see we're trying to have a birthday party for her. She really isn't interested.
To you. Happy birthday to you. Happy birthday, dear baby. Happy birthday to you. Okay, he's gonna blow him out. Ready? He's gonna blow him. Can you have him blow?
She is interested in the Play-Doh, but not so much, really, I think, doesn't understand the birthday party. And here's one more little guy we saw. You can see these children don't look radically abnormal at all. They're beautiful in many cases, but they did have autism. Sorry, one more little guy who has a very assertive mother, you'll see.
You don't want to spill it. It's a cookie. Cookie. Ooh. What is it? What is it? Cookie? Say open. Open. Go look at Mama. Look at me. Look at me. Open. Very good. Good talking.
So one of the things we learned from this was to attend to tiny behaviors that we saw. For example, that last boy did take the cookies to his mother. That was his idea. So he was able to carry out an idea of how to communicate, even though it wasn't exactly what we were trying to do. So we have managed to see these families at when the children were 2, 3, 5, 9, 19, 26, 30, and then now at 32 and 33. We have lost about 35% of the sample, primarily when cell phones came in and we just lost touch with people. In between our visits to these families, we've sent packets of questionnaires and done online questionnaires. And as you'll see, there's really, people are very different from each other. So some of the kids have really seemed to move out of the spectrum. Some have moved into the spectrum when we didn't think they had autism at 2. I also, a really important note, which I think is relevant for those of you in practice, is that many of the outcomes or where they are of the kids who have never had autism are not very different than those with autism who have similar IQs. So sometimes we here get so focused on autism, we forget that other people have difficulties, which I'm sure most of you see. So we started out asking, can autism be reliably diagnosed at age 2? In those days, most kids were not diagnosed until 4 or 5 or even later, and that still happens today. we wanted to try to develop diagnostic measures that you could use with very young children under age 3. And then as the years have gone on, we wanted to know what happened to these children as they grow older and how are their experiences different from children with other developmental disorders. So these are growth curves, and each little red line is a child. And this shows changes in the ADOS severity score. So the ADOS is an observation that is conducted in a standard way with a child that takes about 45 minutes. Out of the score, you get a range from 1, which would be very little or no evidence of autism, up to 10, which is during this time, so just during the 45 minutes, how many symptoms of autism did a child show and how severe were they? When we analyzed these scores, which we were able to collect at all of these different times with different examiners, so 2, 3, 5, 9, and then this just goes up to 12 to 15, we really expected a lot of variation over time because these were different examiners, the kids were changing. But in fact, you'll see if you look at the 2 slides on the right, that there were about 80% of the sample stayed within the same range. They didn't have exactly the same score, but the kids with very high scores, which is the bottom right, tended to stay in that range. And the kids with sort of moderate autism scores stayed in that range as well. We did find 10% of the sample who actually got worse gradually. And these were kids who were not so severe at the start, and again, ended up in this sort of moderate range. And we also had 10% of the sample that really improved significantly. So this was a surprise because we thought working with 2-year-olds, they would be all over the place and that we would have much more variability. This is another growth curve. Here we're looking at changes in language, and this is as parents reported on the Vineland communication scale. You'll see that along the bottom are the actual ages of the children, and along the top are the age equivalents according to their parents' reports. And what's important here are a couple of different things. First, there is a huge variability. At 2, not so much. I mean, there were a lot of kids who did not talk and didn't even do the things that an ordinary 1-year-old would do. So that's at age 2. But there were also kids who were, everyone was behind, but closer to age level. But by the time you get way up at the top, and you could see this is logarithmic numbers, there are kids who are at age level, and there are also a substantial group with this blue line on the bottom who don't have the language skills really of an ordinary 2-year-old. And then everything in between. There are also different trajectories where we had some kids who just changed very, very slowly, as in the blue line on the bottom, and also kids who changed very quickly, but right on course at the top line. But we also had some late bloomers, which are the lines that scoop up in the orange and in the green. So we have some kids who started slowly, but then gradually made a lot of progress. The last important thing, though, here to note is that after about age 5, the lines become straight. So we have the catch-ups. We have the kids who are late bloomers between 2 and 5. But after 5, it's not that kids don't make progress. They do continue to make progress, but the lines are linear. So they're less likely to suddenly spurt up. And that's really important for early intervention. And as Dr. Kasri will talk about, we need to get these kids early and get them started because language changes in different ways after about age 5. It's not that it doesn't change, but it changes in different ways. So we could not predict at age 2 who was going to talk and who wasn't. I think we're getting better at that now, but we couldn't do it from these families. But other things really made a difference. And we also need to realize, and I think Dr. Kasri will talk about it a little bit, that there may be alternative routes and communication approaches that these kids didn't get 30 years ago. So we then asked, what different trajectories do we see in different domains? And are there changes that are more predictable later are there changes that predict adult outcomes? And we looked at things such as IQ and intelligence, teacher judgments of how kids got along with other kids, adaptive skills, achievement skills, parent reports of things like irritability, hyperactivity and withdrawal, and anxiety and depression. And here, the good news here is that parent reports of simple, very common difficult behaviors such as hyperactivity and irritability generally go down as kids move out of childhood into young adulthood. They don't go away. I mean, you could see these scores. This is from the ABC or Aberrant Behavior Checklist, but they do decrease across groups that are both the kids who are more intelligent, which is the lines on the bottom, and also the kids who have severe intellectual disability. So they get better. The one thing that didn't get better in our group is social withdrawal. And here we found that kids who were more intelligent, their parents actually reported more social withdrawal, at least from the parents, as the kids got older. We also looked at the relationship between achievement scores and being independent as an adult. And actually what we found was that kids who could read with understanding, not just decode, not just pronounce the words, but actually understood what they read, were much more likely to be able to live independently by the time they were 26. And we looked at teacher judgment of peer interactions. And here we found that kids who teachers described as being more connected were more likely to be independent as adults. It's also the case, and Dr. Kosry may talk about this, that kids who were exposed to typical kids, who had opportunities either in regular classes or at least regular opportunities to play with other kids who did not have handicaps, ended up doing better. And last, we looked at adaptive skills. And this looks at particularly at the Vineland again and daily living skills. So how much kids can bathe on their own? Can they make themselves simple food? Are they toilet trained? Could they walk across the street by themselves? And you'll see here, we divided up our group with kids who had lower IQs on the left and higher IQs on the right. But what's important here, I think, is the overlap. So although there obviously are relations between how intelligent you are and how much you can do for yourself, about half of the sample of the kids who had low IQs was very similar to the kids with high IQs. And I think what this does is it can give us hope that even kids who don't do well on intelligence tests can learn many things about taking care of themselves, and things like bathing and simple cooking. But also to remember that kids who are very bright can also be behind in ordinary daily living. And we need to make sure that doesn't happen as well. It's hard because many of the parents, by the time kids are older, are exhausted and have many other things to worry about. And so often don't get the support they need, even with bright kids. So in the last few years, our goal has been to try to figure out what makes a difference in the lives of autistic adults. And then we also can go back and look at our earlier data with hope that if we can see milestones or things that did make a difference earlier on that have an effect later on, we can help. So we asked the people in this study, and this includes the parents of children, but these are actually adult children, what was most important to them. And then we also asked parents of people without intellectual disability what was most important, what they thought was most important for their adult child. And then we actually asked the people, the autistic people, who had enough language to answer us. And I think one thing I was struck by here is you'll see that in the gold line, almost everybody had individual goals that they wanted to pursue that were specific to them. And I think sometimes we railroad over these and get focused on big goals, but people wanted to learn to drive if they were bright, or they wanted to learn to make spaghetti, or they wanted to learn to operate a microwave. So we need to attend to those. We also can see that for less able kids and even all our adults, friendship became less important compared to when they were children. But many of the adults and their parents really wanted them to have a romantic partner, which is hard for many autistic people. In the US, housing is also a huge issue as parents age. And then work and finding something to do during the day was very important. So one thing I wrote in red, just so I don't forget it, is that we've kept track of all the treatment that the kids and adults have had in the study over time. And basically nothing has predicted outcome except parent involvement in early intervention in that year between 2 and 3 and between 3 and 4. And the variable was not just having early intervention, because most of these kids didn't have intense early intervention, but almost all of them had at least somebody working with the family. And if the family could stick with somebody and stick with an approach for more than 6 months, that actually had effects all the way up through adults. And with both kids who had very severe impairments and also kids who had who were more able. So we've also then been trying to figure out, how do we represent what is a good outcome for an adult who has limited language and intellectual disability. And so what we did was we took the World Health Organization goals, and here we have social. So we have, you'll see down at the bottom, we have, does the person have anybody who is not paid to work with them and not a relative who they like to spend time with and get to see regularly? So those are the blue on the bottom little tiles. So about half of our sample who had limited intellectual ability had somebody like this. We looked at daily living skills and we broke it at about age 8, which is just that on the Vineland, age 8 means you can bathe, you take care of your own hygiene, you can bathe, and you can do some things around the house. And again, about a little bit less than a half of our sample met that criteria. And then we looked at, what are they doing during the day? Are they doing some kind of regular activity? This is the little tiles down at the right, including supported employment, where they work somewhere where someone helps them, voluntary jobs, going to a center. I mean, what's really depressing is our sample is that more than half did nothing. When we put these together, we find that a very small proportion, maybe less than 20% are blue over here in the big tiles on the left, where they have positive outcomes in all 3 things. More have something, either a friend and good daily living skills or activities, but we also have a substantial proportion who have none of these, no friend, are limited in daily living skills and independence, and no help. So let me remember this little guy. So this is him at age 2, such a happy, beautiful child. And I want you to see him here at 30.
One more time. Can you take my picture?
Just
He
said,
is
take my
kind of
picture.
taking your picture.
I'm gonna smile.
That is a big, should we smile together? It looks great.
So he is just as charming at age 30 as he was at 2. He has an intellectual disability, but he can talk. He has a part-time job with a local business related to his family. He lives with his parents. The parents don't know what will happen to him. They're in their 60s when they are not alive. So that is a worry. But he is very happy and able to do many, many things for himself. Here is this little boy, remember, who is helping Debbie blow the bubbles. And here he is at 25.
Ooh, almost. Score! Can I try?
So that young man really has made progress in the last few years, but he has very severe intellectual disability, seizures. He doesn't talk. What the progress has been, though, is that he is at home all the time. And I think that's a concern for us. He doesn't do very much, but his latest activity is he's been taking a chair out to the backyard and watching the birds, which everyone is very excited about because he's doing it on his own. So here we looked at traditional objective outcomes for adults with autism who don't have intellectual disability. So same strategy. We looked at, do they have a friend? That's down on the little tiles on the bottom left. So the green people have a true friend that they see regularly and a reciprocal relationship, about half. We looked at where are they living, and here we have people, again, about, it's a little bit more than a third of the sample are living independently on their own. Many are still home with their parents, which again, in this economy is not totally out of the picture, but is a little bit unusual for a 32-year-old. And then work, this is whether they ever had a job, an independent job. So most of the sample has had a job, but if you look at any given point in time, do they have a job? Are they working? And also, is it full-time and something that they're happy in doing? It's much more like 20 to 30%. When they add this all up, things do look better for this group. So we have about 25% of the sample who is doing all of these things. We do now have two people who are married and have children. There are, many people, this is a significant minority of people, though, who really have happy, good, independent lives. But we also, again, have about 25% of the sample who have very restricted lives. So remember this little girl who wanted to play with the Play-Doh, and here she is. I don't know if you can understand her, but she lives in a trailer in the back of her parents' house. They live in rural North Carolina, and so she has not been able to get access to services. They're looking at a picture of the United States, and on that picture there is an apple, which is a statue that actually occurs in a baseball stadium in New York. So see if you can hear this.
See, plenty of palm trees, but not oranges in Florida.
Yeah.
I wish I could get some oranges. I heard the oranges are delicious.
They're pretty delicious.
I remember, well, I do see a lot of country clubs around here,
Yeah.
but I don't remember enough in South Carolina being the Gulf state.
Mm-hmm.
Nowhere. Now, of course, Washington, D.C. right here.
Mm-hmm.
I ain't gonna lie, I would love to go to New York if they have a Big Apple. Do they really have a Big Apple?
So they have, do you follow baseball?
Not really.
Not really. One of the baseball teams in New York, they have a Big Apple in their stadium, but I think that's the only Big Apple.
Yeah,
New
lied
York
to
has.
So this young woman has a great sense of humor. She is actually quite smart and able to do lots of things, but it's been very hard to find things that she can do, partly where they live and partly because they don't have a lot of resources or money to pay for things. Remember this little guy who took his mother the cookies? Here he is. This young man has a degree in engineering, but who also who really isn't working. And I'll just let you see him for a second and then finish up.
Oh, it's getting good. It's getting precarious now.
Would you rather live in a cave or live in a tree house?
Well, can I say it depends on the climate and stuff. Some places it might be more comfortable to live in a cave than say a tree house.
Makes sense.
Well, and if you're in a place where it gets hot and humid, like say North Carolina, being in a cave would.
So one of the things just quickly that we have found is that Vineland or ability to interact with other people generally goes up, particularly for people who are more able. But what happens is there's a cliff here when kids leave school, and things start to decrease, and it's something we need to be aware of. We also have found that people do change diagnosis. So if you look here, the blue lines are kids who have always had an autism diagnosis, and these are ADOS scores. The red lines are people who never had an autism diagnosis, and their ADOS scores are lower. But what's important here is the green line are people who, when we saw them at 25, we would say we would not have known this person had autism. And the orange line is we saw them at 25 and we went, oh dear, this person has autism. The point here is they are changing very gradually. The changes are gradual. They are not miracles, but the people who are getting better gradually. For people with very low IQs, the ADOS doesn't differentiate very much by the time they get to be 25 with people that we say have autism. So just a summary, and we can post this video, is that we know quite a lot about what early strengths predict things that will be better. We don't necessarily know how to make those happen. And that's to some degree what Dr. Kasari will talk about in terms of intervention. We have good ideas of things that can make life better. We also can get reports from parents with people who can't speak very clearly, and also from the young adults themselves about their happiness and well-being. And those things for people that can speak for themselves are mostly related to depression and what they're doing during the day. For people who can't speak, whose parents are speaking, they're related to hyperactivity and aggression. So we can diagnose autism at 2. In our study, the only effective treatment was parents' involvement in children's early participation, but we're not a good treatment study. By the time kids are in elementary and teen years, what they need is very different for kids who have severe intellectual disabilities as well. And we need to know not only what are people doing, but also what is important to them and how do they feel about it. We need to know strengths, and that's something that often we talk about in our clinical assessments, but doesn't come up in research. And the main goal here, and this is from the Lancet Commission, is we want to pull up the opportunities with these red lines. If we pull up the opportunities and support, things will be better for everybody. And they still may be quite different for people with profound autism and intellectual disabilities, but it doesn't mean that they can't be better. So this work has actually involved hundreds of people, and I've just listed some of them, and support from NIH and Autism Speaks and the Simons Foundation, and a lot of tolerance from these families and young people who have let us visit them and send them questionnaires and have told us about their lives. So I will stop there. Thank you very much.
Thank you, Dr. Catherine. That was a very applaudable and a comprehensible talk. Before we go on to the question answers, we would like to have comments from the experts. So can I have Ms. Mary Barwat for her expert comments on autism and how we see it in the future?
First of all, Kathy, lovely to see you.
Yes.
Amazing presentation. I had the couple of things that I really liked is, when you said that when children, the parents are trying to decide the goals and how important it is to listen to the autistic people themselves. And that's something really, really important we are beginning to realize now. And of course, the aspect of caregiver involvement, which is very important. I had a few questions, and I'll just ask 2 of them because I know there are lots of other people. So one is that in the study that you did, were there any of the individuals who are not speaking also using any kind of assistive or augmentative modes of communication?
There were. I mean, I think that it didn't make much difference. We didn't have anybody who really shined with it.
Okay.
We did have people who had various devices. And it really depended on partly how much other people used them, like their family and their school or wherever they were.
Okay.
But they didn't have, I mean, they are 30 now, so they didn't have
and that time,
yeah.
yes. Yeah. So our understanding is a lot more evolved now. The other one that it's just a comment and also a question that, so many, you mentioned one young man who's a graduate, and we know so many who've done their graduation, their post-graduation, but they are not able to get or retain jobs. So what would you say were some of the reasons?
I mean, I think part of it is thinking through very carefully what are the skills of this person and how does that fit into the real world. So that young man, he completed an engineering degree. It took him 6 years, so longer, but he did it. And he is very precise and very interested in, how things work. But he also can't tolerate a lot of demands. He gets, overstimulated, and he doesn't live somewhere. He drove a long way to go to university. He lived at home. So trying to think through I think if I had a perfect world, I would have, we think through how can we help him learn to be more independent, because he didn't do that. He always lived at home. And then how can we think about what are places where he could use those skills, because he has them. But if he just goes to a big business, they say, wait a minute, you're too odd, and you get stuck and you go on about things that are important to you. And he can control that to some degree. So I think being very realistic about where people can work and thinking that through, rather than just saying, go get a degree.
True. Thank you so much. I think the good thing is that now there are so many businesses that are making an effort to make the accommodations to employ neurodivergent people.
Yes, absolutely.
I'm done, please.
Thank you, ma'am. Thank you. Can we have Dr. Paul Russell give his expert comments?
Thank you. Thank you, Professor Lord, for sharing with us this wonderfully followed 30-year cohort and their outcomes. I work with children and families with autism, and our experience observation is almost similar to what you shared, that if there is a family involvement, the outcomes are better. One other observation is that if these children fall ill recurrently, especially with mental health concerns, that subgroup of children do not have the expected outcome. This is our observation. What are your observations and thoughts about this?
I agree. I think we do have the same thing. I think we are not great at characterizing what those mental health outcomes are. So we know, for example, that our young women were much more likely to start getting depressed during adolescence than the boys. But there certainly are boys who have always been somewhat depressed. So it isn't that they weren't depressed, but that the depression happens. Certainly ADHD, I think, makes a huge difference for autistic kids, because they could be bright, but if they can't attend, they miss information. And then aggressive behavior. If kids have significant aggressive behavior, either to themselves or others, it ends up often really restricting who will even work with them and what they can do. So I think that is absolutely important. And you're absolutely right. And what's sad is I do think sometimes we could do more to help earlier if we see a child who is depressed, for example, or very severely has very severe ADHD, we could treat that better rather than waiting till it gets out of control. And certainly aggression. We just did a new paper on aggression and found that little kids in aggression didn't predict anything. But if you have a 9-year-old who is aggressive, the chances of them continuing to be aggressive are 4 times higher than somebody who is not aggressive. And we need to treat that. We need to figure out why, what is going wrong, and what can we do rather than just let it go on until the child becomes an adult. And then, so I think I completely agree with you.
Thank you. If I may, can I have one more question, please? Uh, some of the children I initially saw are around 30 years again here. And we see that the family goes through a very complex type of grief. And over many years, still the grief is quite significant. And along with that comes in the burnout of care. And how do you manage in this long kind of a cohort? What are your experiences in handling this grief and the burnout?
I mean, I think those are really good questions. I think these families, I think, were unusual because they were families that more than 30 years ago brought their kids to a clinic when they were only 2 and when autism was considered very rare. So I think the families are tougher than other families that wait longer and hope this isn't really happening. They were right on top of it, and they weren't particularly wealthy or well educated, but that factor, I think, has meant that, for example, we haven't had big racial or education differences from the parents. Well, we haven't had the effects of the differences in the parents until now, when their kids are older and where having no money really makes a difference, no matter how great a parent you are. I think because of that, we have had a little bit less of the grief that you can see in families who have been hoping this is going to be all right and everything will be okay, And also these families have known us descending upon them, every other year. And so we say to them, this is how much your child gained. This isn't what they didn't do, which I hope makes them a little bit more realistic. I do think, though, there is burnout. I think people just get exhausted. And as they get older, it's not like everything else in their lives is perfect. So I think we really need to work on having better support for adults, because I think, as Mary said, there are people who could work if someone would help find that job. And the parents are often really stuck with that responsibility, which I wish they weren't.
Thank you, Professor Lord.
Thank you, Dr. Paul Russell. May I have Brigadier Shuvendu Roy? Sir, can you... Brigadier Shuvendu Roy, sir?
Am I audible now?
Yes, sir.
Good evening, everyone. At the outset, Professor Catherine, it is a fantastic talk. It's very much educative, and as a pediatrician, it is an eye-opener for at least me, because it is very heartening to see that these autism, I should not say children, they're doing so well till 32 years of age, so on and so forth. And whatever we have seen in our case is in India, and especially where we are serving in army, a multilingual problem. Our people are keep on moving around from one place to another. 4-5 places in one place, or years in one place, then another place, and every time their therapies change. These people, they develop at least 6 months or 1 year to develop the rapport with the therapist, and they go to another place. It's the biggest challenge for all the army people, neurologists, for all of us to maintain this thing. And secondly, madam, as Dr. Paul also said, apart from IQ, what I have seen in my personal practice, that most difficult thing to counter in early years is the hyperactivity. They do not sit in front of therapist for a single second. So unless you give them upfront and the medication, the pharmacological therapy, difficult to manage. Madam, what is your advice for this kind of subset of patients?
I mean, I think it is hard for even in the US with military where people move and we don't have the variety of languages that you have in India. I think with the ADHD with the very small kids, I think people are often, if they have trouble getting the child to hold still, they may be trying to do too difficult things. And I think you'll see with, for example, Dr. Kasari's intervention, that you can create interventions if they are really targeted for where is this child now, which may be more like a 1-year-old, even if they're 3, you know, and you have to think about, would I ask a 1-year-old to sit with me for half an hour? No, you know, I might have to move around the room. So I think trying to lower the level of development to match the child's level is really important. I do think, and I am not a prescriber, I'm not a physician. I do think that treating ADHD earlier than I would have thought years ago in autism is important. So I do think using medication. We used to wait until things were absolutely falling apart with a 6 or 7-year-old, and I think that there probably is no reason to do that, given what we know about the medications. But it's harder with a tiny child, with a 3 or 4-year-old. So I think I would be more aggressive with older kids, and then really try to also, the trouble there is you also need to control the environment. You know, we have parents, for example, who have hundreds of toys because they want their children, you know, to do things, and hundreds of toys all at one time is not the greatest idea for a child who has trouble concentrating. So thinking through what can this child really do and starting at that level.
Thank you very much. Thank you.
Thank you. I'll just thank you so much, Professor Catherine. It was amazing. And I just wanted to add, besides what has been spoken, in our country, actually everything is left on the moms. So we found that 79.7% of our moms were clinically depressed. And other thing is, very many times it is overlooked about the comorbidities. Yes, hyperactivity, ADHD is the most common, yes. But you know, we analyzed 1,874 of our children, and we found that 80% had comorbidities. So I think we have to look at it holistically, and I'm really thankful for an amazing talk. I think we can, we'll just request Professor Connie to start her talk, and then after that, few questions which are there in the Q&A. Professor Catherine, if you see if something can be answered in 1 or 2 lines, otherwise we will just answer them live immediately after Professor Connie's completion. Yeah, thank you so much. Professor Connie, can you start sharing? Yeah, thank you.
Oh, it's always exciting to come after Kathy's talks, because I think it's so important that we have these longitudinal data. It's so rare. And I always learn something every time I hear her talk. So I'm going to talk a little bit about early intervention. And I do have disclosures as well. And I think what's really clear is that autism is a spectrum, and you heard this from Kathy. So that saying, if you've seen one person with autism, you've seen one person, is really true. But it's also that a single intervention strategy isn't going to be effective for everyone. We have heterogeneity in how individuals present across a broad range of health, behavior, genetics, background. We heard some of this from Kathy's talk. And there's also heterogeneity in response to intervention, including these kind of in-the-moment changes in health and behavior. So what does that mean for early interventions? Well, I'm going to give you a very US-centric approach to early intervention, because that's what I know. And I know it's not the same across the world. But most children in the United States will receive the same intervention. So they're mostly applied behavior analysis based, and this often means kind of a discrete trial approach. So sort of teaching a skill in a repetitive way until the child sort of gets it. It's not titrated for need, so dose or intensity, but rather what insurers will pay for. So if you have really good insurance, they may recommend that you get 40 hours a week of this kind of intervention. If you have not such great insurance, you won't. And there are, disparities then in who gets intervention. And there are also attempts to standardize the intervention. So in the United States, the BCBA, the sort of ABA therapist is really has taken over insurance. but it falls short with this ability to train a workforce. We have shortages just like everywhere in the world these days. And the training is often just very brief and honestly not good enough. There are also some myths that we're dealing with, continue to deal with, is that this kind of ABA discrete trial training is the only evidence-based intervention approach. Families are still told this in the United States. It's certainly not true. And they also might say that children need a one-on-one intervention, that they shouldn't have a group or a school-based, kind of intervention, and no inclusion, right? So the idea is that the child with autism has to earn their way into a general education or inclusive setting. And as Kathy said, we know from a lot of data across a lot of different individuals that having access to kind of the typical school experience is better for individuals, whether or not they have intellectual disability. But new research is going to provide us with insights, hopefully, into who benefits and why. So past research really focused on samples of convenience, and still does in some cases, in that the people that come into a research study are those who have knowledge of the research study. They're often well-educated and in the United States, white. And the studies often will exclude kids who are intellectually disabled or complicated, minimally verbal, or behavioral. But I think that the new research studies that are being done now are trying to address the entire spectrum. And in part, we're doing this through subgroups. So really focusing on intellectually delayed or minimally verbal children, or especially in the United States, minoritized, marginalized populations. So I'm going to very quickly just give you an example from one intervention model called Jasper, what we've learned, and then a little bit about where we need to go. So this is an intervention that we developed at UCLA called Jasper, Joint Attention, Symbolic Play, Engagement, and Regulation. It's really focused on sort of those developmental needs of pretty young children from early childhood to about age 8. It's modular. It's one of these naturalistic developmental behavioral interventions. So it's still within that umbrella of ABA, but it's much more developmental. So it incorporates both behavioral and developmental strategies. It's very targeted on the social communication difficulties that young children seem to show early on. And we think about it sort of modular, building a comprehensive intervention around this one module, but adding in others. Okay, so our intervention targets are these kind of building blocks of early development. So joint engagement, being engaged with other people, playing, social communication, and being regulated. So why joint attention? So there's been a lot of research on children with autism, but also just children in general, that joint attention, or this ability to share an event with someone else, or to use a gesture to share an event. For example, the child who brings a toy to the parent, like Kathy showed in that one video. So that child bringing something to the parent to show is great. Even if they're not looking at the parent, it's still a gesture to share. And we know that children who do more of those kinds of gestures are actually going to be children who are more likely to gain language, spoken language. Why symbolic play? Well, so play is difficult for children with autism, and symbolic or imaginative play is harder than functional play. And also social play, so playing with other people, is harder than just playing by yourself. And so the problem for a lot of kids with autism is that they may have very restricted interests and repetitive behaviors that will limit their ability to play with others. And so in Jasper, we work both on the development of play skills, but also on those social aspects of play. And that's a pretty universal ability for young children. They kind of learn through play. And then why engagement? So engagement is different from joint attention. We think of joint attention as these gestures to communicate, but being engaged, staying connected to another person is really the foundation for language learning. And so we think about the development of engagement. So children go through sort of just being person engaged when they're really young, like a 6-month-old baby, but then they become maybe more object engaged once they discover that there are toys or objects in the world. And as they get towards the end of the first year of life, they're really combining objects and people in important ways to learn. And I'm going to show you a little video. This is a little girl who was 21 months of age. She got the diagnosis of autism, and she's playing with her mom with kind of a standard set of toys. This is the toy that baby selected, and the mom is going with it. So let's watch her for a second.
What else can you do? Can you put him on top? Can you put him on top? Yay! On top.
Okay, so there's a lot in that little tiny clip that tells us that this child is actually object engaged. She's not really paying attention to her mom. In fact, when her mom suggests something else, she doesn't follow it, and she goes back to trying to put these little rings on the pole. So what we recognize from this is that this toy is too difficult. This is not at this child's developmental level. So while she chose that toy, it's too difficult, and the baby is using all of her cognitive resources to actually do the toy. And so in intervention, we're going to teach mom that, what the child's play level is, and mom is going to then facilitate the child playing with these toys that are actually at a lower play level. And so when she does that, you'll see that the child is more engaged. Right, so it's down a play level, but now baby can pay attention more to mom. So now we would code that as being jointly engaged. All right, let's see. So why regulation in Jasper? So calm and regulated children are definitely in a better state for learning. And so here we're going to use some behavioral strategies. And why do we focus on those targets? Because we know that these behavioral skills are very important to development. So language, being able to speak in phrases, is really important by the time children enter kindergarten at age 5 or 6 in the United States. And we know that joint attention skills, those gestures, those communicative gestures, predict to language. So they're important targets for intervention. Play skills tell us what children understand about the world. It tells us something about cognition. And then joint engagement is really an important mediator, or kind of the glue that holds all of this together. The other reason we focus on these targets is that interactions can be really difficult for families. So I'm just going to show you one little video of a little boy. He's already, so he's just turning 3 years of age. He's already had a whole year of 20 hours a week of that ABA discrete trial training. So he is getting a lot of intervention, and he still has absolutely 0 words. And he doesn't like to play. So his mom came to us and said, he doesn't like to play. I want to learn how to play with him. This is his first Jasper session. So you'll see.
Oh my goodness. Oh my goodness. Oh the buns. That's what I done.
right? So he is not enjoying this at all. And part of the reason is he has a toy that he completed and he was done. And when she tried to expand the play, he wasn't having it. So I'm going to show you him later. Okay. So Jasper targets then are to have specific strategies to help families or teachers or therapists engineer learning opportunities so that we can work on these developmental targets. So what we've learned, we've implemented this with therapists, with caregivers, with teachers, and even with peers. And there's a lot of randomized controlled trials that we have done in various contexts. And typically we have pretty replicable findings. We can always increase joint engagement. So the duration of time that the parent and the child can actively be engaged together. And then depending on age and subgroup, the outcomes are more variable, as you would expect. So sometimes an increase in play skills, sometimes symbolic, sometimes functional, increase in joint engagement, or joint attention. So those initiating of gestures, and an increase in actually language. But methods matter. And there's no standard of care for autism intervention. So we have tried to control some of this in our studies. So one solution is to compare two viable interventions. And we also will situate the intervention in the community where we want the change using implementation science methods. So in one example with parents, we've given all the information to the parent that they need or that we think will help them to increase their child's communication and language. Or we coach the parent through with their child. And what we find, this is a study of toddlers, about 86 toddlers, I think, where with the child initiating joint engagement, it only occurred when we did the hands-on intervention with the parents. And that if we give the parents information, they really liked that, but it didn't change child behavior. And so it's probably important that caregivers have access to somebody who can help them actually engage with the child in productive ways. And so this was a very short-term intervention, 20 sessions over 10 weeks with a 6-month follow-up. And you can see that in the Jasper group, there was increases in joint engagement, play diversity, that's kind of the flexibility of play, and play level. And the information sharing group loved it. They had decrease in parenting stress, but not increase in their children. And then we've also implemented this with teachers in schools, and schools require particular adaptations. But it's important to think about schools, at least in the US, because all children go to school, and in school, you're going to see children that are more complex, that have more diversity. And so you're more in the real world with the population of autism. So we have done different models. We've done a one-on-one model if that's what the school uses, but we've also done small group peer models if they have peer rotations. Here's a study where we did this in centers in New York City with toddlers with autism. It was about 112 toddlers, and we did a wait list randomized controlled trial. And again, we have teaching assistants that are doing the intervention. They can get to high fidelity in a short period of time, and the percentage of child-initiated joint engagement increases for those who are getting the intervention versus those who don't. So I want to get to personalizing, which I think is the future of research in early interventions. And this is really in response to this idea that there's a lot of heterogeneity. You can give the same good intervention. Let's say you give them Jasper. There's going to be a range of responses to this intervention. So we really need methodologies that can personalize, tailor, and target that intervention so that we understand for whom the intervention works and why it works. And so the adaptation in the intervention is based on the child's response. And we do an approach called an adaptive intervention design, which is really meant to systematize clinical practice. So if you think about that good clinician that everybody wants, They do things sort of intuitively, naturally. They're really good at what they do. But it's difficult for them to actually train the next person because they're not even sure of what they do. So in an adaptive intervention, you're using a sequence of decision rules to specify whether, how, when, and based on what kind of measure, you're going to change something about the intervention in response to a child or a parent. All right, and these, the sort of randomized part of this is called a sequential multiple assignment randomized trial. These are my colleagues who are statisticians who sort of developed these methods. And I want to talk briefly about one we did for minimally verbal 5 to 8-year-old kids. So these are kids past that window of so-called early intervention, and they're still not really fluent in spoken language. So these were children who had fewer than 20 functional words. They had far fewer that they used on a daily basis. They'd already received early intervention, so they weren't naive. And we gave them, because most of them had had kind of a discrete trial ABA approach already, we wanted to give them something novel. Most of them had not had Jasper. And we blended Jasper with a spoken language intervention, which really just prompted spoken language. So blending those two interventions together. And we randomized half of the kids to get a speech generating device, an augmentative device, because the controversy at the time was whether or not this would inhibit or delay language, spoken language, even further. So parents didn't want a device. Some speech therapists didn't recommend a device. And we had a design. This is our design. So we randomized children to get this JASP EMT intervention with or without the AAC. And after 12 weeks, we then measured the response. And our outcome was, in this case, spoken language. We called socially communicative utterances. So we just looked for an increase of 25% across a series of measures at week 12. And for kids who were early responders, they just continued on with the intervention they started with. But for a slow responder, if they didn't have the device, they could get re-randomized to get the device, so you see here, or to get an extra session a week. So these kids were getting 2 sessions a week, and now they could get 3. Or if they already had the device, we didn't take it away, but we would then give, if they were slowly responding, we would intensify by 3 times a week. And then we did a follow-up. So what did we find? Well, we found that socially communicative utterances increase pretty quickly with the device. And we're saying spoken utterances. So this black line are the kids who got JASP EMT plus the device. And this is the 12-week point. Here, we actually brought in parents as well, and you can see it still goes up. And then this line going down is the follow-up. And yes, it does go down, but it's still higher than baseline. And the kids who got JASP EMT are making slow and steady progress on the outcome, but it's much faster with the device. The kids who got the device also had more novel words and more commenting language, so joint attention language. Most people with children who aren't speaking will just work on requesting. So we worked on commenting as well. And their engagement increased. So here is that sort of the importance of the interaction. It wasn't just giving the device, it was the intervention that was helping. So these are children at entry, midpoint, and exit. This is black bars are adult initiated joint engagement. So the adult sort of prompting or facilitating the engagement. And the gray bars are the kids actually initiating that engagement. And that is increasing over time. Okay, and I want to come back. I want to give us time to have questions. So I'm zipping through this. I want to come back to this little guy that, you know, didn't like to play and was crying. So we knew right away that we needed to change the toys. So we, again, go down in play level. We bring in a toy that doesn't have a completion point. So this little guy, thought he'd completed the toy and he was done and he wanted to move on or get his reinforcer. So now we have a toy that doesn't complete, and we brought in an iPad with software. In this case, we use Proloquo to go, and we have little icons that match the toys that we have in the room. This is literally the second day. So let me show you.
People on people on land.
So he is already using 2 icons. So I would say that he has, a language. He can use those buttons to communicate. We didn't have to really teach him. We just have to model. So he's got these skills. So he's had early intervention. He's still not talking, but he's using the device and he's regulated. So we're still going to work on spoken language because it's more efficient. Some kids will always need to use a device to communicate, and some kids will use it as a transition to spoken language. So now here he is 2 weeks later, different therapists, they're working on saying a word.
Blue, black. Here's brown. 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 On. Brown. Brown on. On.
Right. So he's under his own little pressure to press those buttons to communicate, which is interesting. But he is trying to say the word on. So he continued for about the next 3 years. As he started to learn to use spoken language, he still used his iPad, mostly to repair when other people didn't understand and to regulate himself. He had many, many, many files on that, on the iPad for his communication. And he, he's a kid who could actually read. So we discovered that in the course of intervention. We do assessments on reading for minimally verbal kids. Some are, about 1/3 of the kids in that study I showed you could read. And this is that little boy, now at 7. He's actually in an inclusive setting. And he sent me this little video to say, Happy Mother's Day, Dr. Connie. Looks like he's probably reading, because I'm sure his mother set him up for this.
Hi, Dr. Connie. Happy Mother's Day. Well, Sebastian, Kitty is fun.
Right. Katie's his therapist, and he's telling me she's fun. Okay, so he now doesn't use the iPad at all, and he uses, spoken language. And so the goal, the message here is that some kids need, well, actually all kids need access to communication, and some will need an augmentative device. Some will transition to spoken language, some will continue to use it, but it helps to regulate and help them communicate with others. All right, so summary. We can target important developmental areas and improve social communication and language outcomes for autistic children. There's a lot of research in this area. We know that we can do this early on. But what seems critical is what and how we target these skills and at different developmental age groups. Methods matter. We need to pay close attention to how we're conducting research for rigor and replication. And the future really is about personalizing intervention and learning from the application of these new designs that can really help us with clinical practice. So thank you. And hopefully we have a few minutes for questions. Let's see.
Thank you, Professor Connie, that was a very lucid talk on the early interventions that can be provided to the children. We have a couple of questions. I've grouped them into, for the lack of time, I've grouped them into group questions. So first questions I will, people, now there are questions which are like, what is caregiver stress and what is the threshold of starting medications, and whether these caregivers were moms or other family members. And do you have any broad autistic phenotypes among immediate caregivers?
Wow, that's a lot of questions. Okay. So we're on any of the kids on medication? No, most of the kids are not on medication in early childhood. Some will have seizure medication, but not many of our kids had seizures. In the older group, yes. But I would say that most kids are not on medications and that people are fairly conservative. I know Kathy had said that, you know, starting ADHD medication earlier. In my experience, it hasn't been that effective for most families. But as kids get older, you'll see that they're more on medications, you know, for anxiety or ADHD. I think there's a lot we have to learn still about the application of medications.
And
in Professor Kathy's cohort, whether the medications were there used quite frequently or not? Professor Catherine?
Oh. I mean, by now, as adults, very many people are on medication. But as kids, no. You know, in those days, I think very few of them had medications until probably older school age, like or early adolescence.
Professor Connie, there was a question regarding the age at which Jasper could be, age range where Jasper would be effective, and do gains in joint attention and engagement translate to better social skills and language over time?
Yes, we have some studies that we've followed up to about age 12, 8 to 10 years of age. And that was prediction to language from early joint attention. So you do see those predictions over time, but I think we don't have enough longitudinal data. Our longitudinal data is usually brief, like 6 months at the most. And that's what's so important about Kathy's longitudinal studies, because they're so rare. And I think that we need to have more of that. So in my research, I'm really trying to do short-term research to see what we can potentiate, you know, what's possible in a short period of time. And then, of course, you know, if we could, it would be better if we could follow up long-term.
There is a question on how do we rate or measure the quality of a child caregiver interaction? And was the intensity of therapy a factor determining good outcomes? Professor Catherine?
Oh, how do we measure caregiver-child interaction? So we look at, it depends on the study, but we will look at parental strategies that we teach them in terms of facilitating engagement or communication with their children. And then the engagement states is really work from sort of the developmental literature, Lauren Adamson. So we try to use things that have been validated in, you know, other sort of areas of child development. And then what was the other question?
Ma'am, it was intensity of the therapy that is being provided. Does it determine the outcome?
So probably in general, I would say no. That the myth is that you need a particular intensity, and the reality is that different kids need different levels of intensity. If you have a child who is really intellectually disabled, maybe he's an eloper, you know, that needs 24/7 care, they need more intensity just to keep them safe than a child who can go to school and can function in that kind of environment. So intensity, I don't think that there have been there hasn't been great data on showing that intensity makes a huge difference in early childhood. I don't know if
I mean,
you would agree.
I can add just, I mean, we didn't assign an intensity to the families that we saw, but we did find that the kids who were developing the slowest got more intensive treatment, which is good. But we didn't find any effect of intensity. We did find effect of parent involvement and then sticking to a kind of therapy for a while. So not moving from thing to thing to thing. Which is probably partly the parents and partly finding a good therapist.
Yeah.
So, ma'am, there's another question. Does transcranial TMS affect the outcomes in autism? I think AIMS has done a lot of studies on that. So I think Dr. Shipali can take on that.
I don't know whether Dr. Catherine, you had some TMS in your cohort being transcranial magnetic.
I don't think anybody has.
We just completed an RCT in which we've done a theta burst kind of a pattern, and it has shown some improvements. But yeah, it is right now only in the research state, not in the clinical stage, which anybody's asking. I think Professor Paul Russell has written something for Connie. Some 2 questions. Dr. Paul, you can ask, please. And then the other experts can also say before we can actually 2-3 more minutes, and then we can have the final words from
Yes,
Professor
please.
Catherine and Prof. Connie. Yeah.
Thank you, Dr. Shafali. Professor Kasari, this question is, the most difficult thing to bring about in a child is the language and the social language. Jasper is very impressive in its RCT approach. What is the number kind of needed to treat? The NTT for the Jasper.
What is the number of for the
yeah.
RCT?
Yes, so how many children do we have to treat before we see one child improve in his or her language ability with Jasper?
Okay, I'm not sure I'm understanding the question, but in the RCTs, so we have a lot of pilot RCTs, and then we try to fully, have a fully powered RCT. So over 100 kids.
Yeah.
Yeah.
So the effect size?
Oh, the effect size. They're usually small depending on the outcome.
Okay.
Yeah.
Thank you. Does it also improve the theory of mind? Because I see some of the children anticipating from the mother what to give to Professor Connie. So, so is it also a way of improving the theory of mind?
I didn't hear that. Did you guys?
Sorry, I think my line is not clear. Sorry, thank you.
Sorry. Yeah, it dropped out.
Mr. Paul, can you repeat it fast, please?
I can also see
one. Yeah.
Sorry, am I audible now? No.
Volume is low, sir.
Volume is low. Okay.
No, it's okay. It's okay. It's good. It's
okay.
good. You continue.
Okay.
You stay
So
put wherever
first
you are.
one is I wanted to know the numbers needed to treat. And the second one is that does the Jasper approach also improve as a secondary outcome the theory of mind in these kids?
Yeah, we haven't always looked at theory of mind. Joint attention has been related to theory of mind in sort of longitudinal studies, but we haven't done, because the kids are still pretty young. So doing a theory of mind task with a child who's not even like developmentally 4 or 5 years of age is kind of tricky. So we haven't used that as an outcome as much. Yeah, sorry.
Thank you.
But that would be interesting.
Thank you, sir.
Mary, you have to say something. Mary, you have some question.
No,
and your comment.
Hi, Connie.
Hi.
I just had how are you? That was a great talk. And I was just wondering, you said that, the transition from AA to speech. So how do you determine when the transition is to happen? Because we find that some kids, they have started speaking, but they sometimes get stuck. The thoughts are there, but they can't get them out. And if they still have access to the AAC, they find it easier to communicate. So how do you determine when to do the transition?
Well, the kids tell us when it's time to transition. They just stop using the AAC.
Okay.
They find that
They stop using
speech
it.
is just more,
So you
yeah,
go with
I have
what the
lots.
kids are doing.
Pardon me?
You go with what the kids
Oh,
decide.
yeah, absolutely. Absolutely. Yeah.
Good. Good. Yeah,
Mhm.
thank you. That was my question.
Thank you. Thank you. Dr. Kvina Kalra, ma'am, you want to ask something, comments? And Dr. Shuvendra?
Can I ask one more?
Good evening, madam. It is a very, very educative talk. I have just simple one basic doubt. We keep on telling these parents as reduce the screen time as much as possible. And in view of these iPad-based interventions, how to keep a balance?
Say it again. How do you balance?
Ma'am, you always keep on telling the parents that you reduce the use of screen time, reduce as much as possible. No screen time as much as possible for autistic children.
Oh boy, I cannot understand. I'm
Use
sorry.
Madam, you always practice this to the parents that reduce the screen time for autistic
Oh,
children. It is
screen
harmful.
time.
Screen time.
Screen time, yeah.
So, but now in view of these iPad-based interventions, how to keep a balance between the two?
So the iPad that we use with the children is for communication only. So you lock out YouTube, you lock out everything else. And actually the little boy I showed you using the iPad, he knew about an iPad. He loved playing with the iPad, and his mom said, oh yeah, he knows about an iPad, but he immediately used it for communication and didn't, we locked out everything else, but he'd never used it to communicate with, right? So almost all the kids these days seem to have, knowledge of iPads or iPhones or something, but it's pretty easy to get them to use it just for communication. And then, yeah, I would probably not recommend that kids spend a lot of time playing on iPads or with YouTube, right? That's the goal, is to get them to interact more with kids, other kids, or with people.
Thank you, ma'am.
Mary had a question. Mary, you were asking another question.
Yeah, I had one more question, which is how comfortable are schools with children who use AACs if they come with the iPad with their app on it, etc.? Are they comfortable with that?
Probably not very comfortable, but probably not. So that's a lot of work that has to be done in schools and in training of teachers and paraprofessionals, especially in inclusive settings. So, it's equity. It's not everybody gets the same thing. People get what they need. And so sort of getting that message across is really important.
So it seems that it's as hard in the US as it is in India.
Yeah. Oh, yeah. Yeah, we spend a lot of time talking with teachers and going into schools and advocating, and then teaching the person with autism to advocate for themselves at some point if they can.
Very
important. And if they can't, the parent has to.
Absolutely. Yeah. Thank you. Thank you so much.
May I request Professor Catherine to give some take-home message?
Well, I think Connie and I were a good pair in terms of describing, what's important. And I would just say, I think families are really important. So involving the parents in and sorting out what parents can do and how they can be involved. I don't think they have to be the primary person that provides intervention with their child, but I think it's really, really important to consider what they can do and their knowledge of what will help and ways to address their goals. And then I think the other thing which fits with what Connie was saying was there's so much variability across people. And it's really important to look at how things change, because mostly they change gradually. But I think you can, just as in Connie's research, you can say, wait a minute, this isn't happening very fast. What can I do to speed it up? and in our research, we saw, I mean, they're very gentle changes that sometimes resulted in people who really moved out of the autism spectrum and other people who had a worse and worse time. So trying to attend to what's going on and the individual differences, not just in the diagnosis, but in other issues such as whether they can talk, how do they communicate, and then other, as a number of other people have brought up, you know, are they very, very active or aggressive, or what else is hard?
Thank you, Professor Connie.
Oh, am I going to say some last statements? So
Yes,
I would
take home
say-
messages.
A take-home message was, so I would endorse everything that Kathy said. And then I would add that I would never give up on speech communication. I think that there's no particular cutoff age. It gets harder as kids get older, of course, but the main take-home message is not to give up, just to keep working at it and having hope and expectations.
Thank you. From our experts, would you like to give some message before we wind up? Mary, Dr. Paul, Dr. Shubhendu,
Thank you,
Dr.
madam.
Kalra.
Educative talk. Thank you very much.
I would say believe in the parents and believe in the children's ability to learn. Because we very often give up on them saying that, you know, they can't, because they seem not to be able to.
Dr. Paul?
The other advantage I see when we involve the family is, for me, the children, most of them are, a majority of them come from far northeast of the country. It's once in their lifetime visit to us. So training the parent, giving the skills when they come in as a co-therapist, gives the continuity of care to them, to the children when they go back home, where there is no, real resource available. So the continuity of care and later on follow a distance kind of a monitoring also becomes much more of a reality when we train and have parents by our side in helping these children. So family is a must when we try to help these children. Thank you.
Thank you. Professor Kalra, Rajita, Mahesh.
Ma'am, it's a very educative talk, something new that we've
Okay.
done. And ma'am and I was ma'am's student. We worked a lot on early diagnosis of children with autism.
We've developed a screening tool 0 to 18 months, 0 to 6 months, 6 to 12, and 12 to 18 with her thesis. So yeah, we're trying to pick them up early. Yeah. Yeah.
Okay. Now,
Dr. Kalra? Dr. Kalra,
yes,
you
yes.
please, yeah.
Yeah. We come from a country which doesn't have an insurance backup for children. So therefore, our continuity of giving them therapies, interventions is rather limited in terms of financial ability of the family. And since a lot of them, 30–40% easily, are significantly hyperactive, impulsive. In my practice, what I found is that if they satisfy the DSM-4 criteria for ADHD, CBCL positive, I find giving them a very short course of medicines to reduce their hyperactivity, impulsivity, improves considerably the chances of success with intervention. How would you react to this practice parameter?
I mean, I think it's reasonable. It partly depends. I mean, I think as Connie was saying, generally, at least here, we wouldn't give very young preschool children stimulants just because we would feel like there are other approaches. For example, choosing appropriate levels, as Connie was talking about, also often reduces hyperactivity, and having ways to get them to play where they know what's going on. But I think, I mean, again, this is not my research. It would be others. I do think it has helped children as you move towards school age. There, again, first attack should be, are they learning something that makes sense to them? The second issue, if they're still very hyperactive and can't attend, then I think it's worth trying stimulants, just because we know so much, and other meds. We know so much about those medications, and we can see relatively quickly if they help. I think it is important. I mean, we do know that there are more side effects in autistic kids, and there are more kids who don't do well with particular medications. So it's really important to come back to you, and let you monitor this so that we don't have kids getting meds that are not helpful. I don't know, Connie, do you want to add anything?
Nope, I think that's right. Yeah.
Wanted to flag one more thing which gets very commonly missed in India. People don't talk about sleep. And most of them have sleep issues, and those who have nighttime issues, they're going to behavior in the day is be reported to be bad. The quality of life of the child, the siblings, and the family goes for a 6. So I think that sleep hygiene and sleep onset latency related, if whether Meluset given or the sleep hygiene, they don't talk about it. I think that is something to be seen. And as we say, this year the theme is colors for World Autism Awareness Month and World Autism Awareness Day. So I think we should celebrate the diversity of the abilities and try to maximize each and every child's potential. But my only thing what bothers is when, all these interventions, you need some amount of cognitive level, because some of them who have a severe ID associated really worry that what do we have in store for them? That is always bothering, I mean, that is something. I don't know if you want to add something at when we're just winding. My question to you is, because those who have cognitive impairment severe, how to help them, all of them, all the AAC and everything else, you need some amount of cognition, level after which you can act, So there are some who are really bad situations. So they are in a fix, and we have quite a number of them as well.
So I was going to say that I don't know that we have good assessments for understanding how delayed or impaired kiddos are. So sometimes we think, oh my goodness, they don't have enough cognition, and then they surprise you. So I think that you need to have multiple ways to measure and to observe and to take the family's, descriptions about the child, because a lot of times there's some spark of something that you see that maybe isn't on a standardized test. So I don't know. I mean, I think we need to be pretty open-minded about how we approach, and we need methods that can be targeted and personalized. I mean, I could give you lots of examples of kiddos that I've been just really surprised about. It's great. I don't know, Kathy, you may have a different.
I mean, I think I'm more I don't know, negative sounds horrible, but I think I really agree with Connie's point that people can keep learning. But I think it is really important at some point for families to be realistic about what's going to happen and to be thinking about what is useful for this child to know. And I do think that that's, for example, trying to teach, I mean, as Connie said, some kids can read and surprise us, but trying to teach a nonverbal child who can't read and who doesn't consistently recognize pictures to read when they're 9 years old, I think is not good. We should be figuring out what will help him, and what can he do? And then realistically, we need to give families help. I mean, at some point, there really is, that someone needs to make sure the child is safe, which families can't always do if parents are working and there's other kids. And so I think trying to balance the fact that we can always do better, and we don't want to give up on people, but also that some people are going to change slowly, and then figure out what makes a difference. Does it make a difference if this child can dress himself so nobody's dressing him? Does it make a difference if he can tell someone or communicate some way that he's hungry or in pain? So, and I think that is hard. And at least my experience in India has been that many of the kids who get autism diagnoses also have significant intellectual impairment, and people don't necessarily sort that out. But I'm a test person, which is not fair. So
No,
you know,
no,
I,
you're right. You're right. You're right. We see more than the 40% reported from the West. Our intellectual disability part is much more than what is reported in the West. Yeah, you were saying something, Connie.
Well, I was going to say that, I mean, I agree that adaptive behavior in the long term is really important, but reading can be important. And so for that 9-year-old that can't recognize pictures or read, maybe now is not the time to teach reading, but to teach those building blocks towards picture recognition. You know, if you think about it in a developmental frame, you're just going to try to build up those skills, and you don't know where it's going to go. Maybe as an adult, that person reads. Again, I just wouldn't give up. And I would really think developmentally about the skills that a person needs to function in their world. And reading may be really important. It may not. You know, it just depends, right? Certainly taking care and being independent and having happiness is important. So we want to work towards something that interests this person that they can do and be functional. I'm very positive about, I have a very positive outlook.
Thank you so much. We had two amazing women and amazing global icons for autism. Thank you so much for having joined us and enlightened. Really grateful to you. And next week we go to Origins of Complex Children and Youth in Autism Spectrum Disorder with a speaker from North America itself. Uh, and today we were not joined by many of our experts from Turkey, Malaysia, and Pakistan and Bangladesh because of Eid being there today and tomorrow. So we have had less people from there. So next time they'll be there. Thank you so much. Really grateful to you. Looking forward some more guidance and support. Bye. Thank you. Good night.
Thank you.
Good night. Good night. Good night. Good night.